in dystrophinopathy work, we know that it takes a village to care for these patients, and it's a really interdisciplinary experience whenever we're trying to optimize, whether it be standard of care or an intervention that we're doing. And so there was a huge focus, as always is in the symposia and in the posters, about how many different collaborators are involved to optimize outcomes in this disease. And we're going to need to continue that interdisciplinary approach in this space. But gene transfer brings up new issues that we haven't really had to face before in this disease. In my standard clinic team, in our clinic approach, I have a cardiologist I can talk to. I have a pulmonologist I can talk to anytime because we work very closely around these patients every week. But I don't have an immunologist that I know so well related to what we've been doing other than this new gene transfer work. A GI specialist is involved a lot of times with our patient population, but the complications of gene transfer, specifically when it comes to GI work, are pretty unique and need expertise there. Same with renal function. We've known there's been a nephrology aspect to this disease for a long time, but the complications of gene transfer, if you have a hemolytic uremic syndrome-like response, or there's an issue with long-term renal damage that we may uncover in some patients, need that expertise also. So all of these collaborators are so important, and then we need all of the administrative collaborators to make this effective in the clinic. How do we get access to these treatments if they're available? How do we ensure patients can actually come to clinic the way that they need to optimize their standard of care and be monitored appropriately for the short and long-term effects of potential toxicities and tolerability issues? We need social workers, we need nurses, we need office coordinators, we need all of the people that are involved in making sure that families have an optimal experience of the clinic and get to the teams that need to care for them. And these resources need to be increased tremendously for our space to be able to manage something of this magnitude, because we're doing something equivalent to organ transplantation or to a surgery, where we're doing something irreversible in the patient, and we need the appropriate infrastructure to make sure that that's done in a way that's safe and that is optimal. I can't stress enough how much these resources are needed by our community, because each person going through a gene transfer experience has a tremendous volume of oversight that's needed immediately within the weeks, up to maybe 3 months after treatment seems to be the trend most of the time in research trials now. But then also a lifetime of follow-up in terms of optimizing their experience of the disease relative to having been treated. And we don't know what that phenotype looks like yet. So we need interdisciplinary collaboration to make sure that we're appropriately managing all of the different multisystemic aspects of what happens in dystrophinopathy at baseline, but then superimposed on that in dystrophinopathy treated with gene therapy is a whole new world that we need to understand together how to do that the best.